Okay, welcome to the live demonstration of the shoulder using ultrasound-guided technique. We're using PRP. So our patient today has a few issues. She's got some rotator cuff tears of the supraspinatus subscap, maybe a little bit of fraying of the infraspinatus. She's got a little more advanced arthritis in the glenohumeral joint, which is not allowing her to fully abduct. Arthritis in the AC joint. So we're going to do a very comprehensive treatment of all those areas. So we'll be hitting the rotator cuff, all three of them. We'll be hitting the rotator interval and the coracohumeral ligament coming off the coracoid to the humerus, creating that rotator interval here. We'll show you that. I'll do a suprascapular nerve block as well to kind of block the area of pain, which we'll get from this area over here, and block that suprascapular nerve, which will innervate the joint, the labrum, and the two rotator cuffs. We'll get her AC joint, and we'll also get the stabilizing AC ligaments with the coracoacromial ligament and the clavicular ligament coming across this way, kind of stabilizing in a V shape there, stabilizing the movement here. So we'll get that ligament as well, along with the coracohumeral ligament, rotator cuff. We'll get her labrum in the back. We'll get intra-articular injection from the back as well. Yeah, so let's first get her kind of cleaned up, and then we'll get the area numbed up, and then we'll start looking at some structures. Get her covered here. And let's get her clean. A little cold. Now there's different positions that we want to put the body in. So when I mark these areas, I put her into different areas. So the first thing you want to do when you're going to be marking is you want to mark the areas of injection using her anatomy. And then the positions are very important when you're marking. So for injecting the AC structures, the coracoid process, labrum from the top, the nerve block, labrum from the back, interarticular, the body can be in a neutral position. So this is a good place to mark those structures. So the first thing we're going to do is fill the lateral border of the coracoid acromion. You can trace that out. It's going to come anteriorly. It's going to articulate here with the AC joint with the clavicle. On the posterior surface of the clavicle, where it comes over here and articulates in with the scaphoid, this little notch here allows us to go straight in and get the labrum, and then from back here we can get the suprascapular nerve in that supraspinatus fossa. The other things we can mark neutrally then is if you go just off the posterior lateral border of the acromion, you can just go straight inferior. That there, if you put skin blebs there and there, that's going to allow you to get intra-articular but also hit the labrum from both of those spots, kind of fanning along the labrum from both of those spots. AC joint we can hit in the neutral position, because when I say neutral, AC joint doesn't change with arm rotation. Coracoid process we can get with all the muscles coming off it, as well as the two ligaments stabilizing the clavicle. Now the rotator cuff, we have to put those in certain positions to be able to inject those. So to get the supraspinatus muscle and tendon insertion, if we internally rotate an adduct, so hands in the back pocket position, it pops out the greater tuberosity anteriorly, so we can inject from there. So I'll put a skin bleb there, there, and there, so I can get it with the ultrasound from different planes. The subscap tendon is going to be almost from a similar spot, but if we externally rotate, it brings the lesser tuberosity over, and I'll put a skin bleb there. We can also use our supraspinatus skin bleb to hit the subscap tendon. From a externally rotated position as well, we can get the coracohumeral ligament coming across, inserting on that lesser tuberosity, creating the medial coracohumeral ligament, which spans over the top of the biceps tendon, and then inserts also on the anterior aspect of the lesser tuberosity, and creating the lateral coracohumeral ligament. All those together create the rotator interval, and that coracohumeral ligament is very important for stability of the rotator cuff, because it helps with attachment and also stabilizes the biceps tendon in the groove there. To get the posterior rotator cuff, we're going to externally rotate. When we externally rotate, it's going to bring the greater tuberosity posteriorly, and then we can get the insertion of the infraspinatus and teres minor, if we had to, on the posterior aspect of that lesser tuberosity. I usually put a couple more skin blebs here and here to scan the rotator cuff as it spans through this interval here to get kind of that blending zone between the supraspinatus and the infraspinatus tendon. Posteriorly, neutral, like I said before, we can get intra-articular, we can get posterior labrum, we can get the labrum here. So let's start numbing her up a little bit. So we use lidocaine. If we do anything deep, then we use ropivacaine. So I'll put a few little blebs here. You ready to get numbed up? So those I'll use for the labrum and interarticular. This one's going to be for the infraspinatus tendon. I'll also redo that a little bit deeper once I get into external rotation. From here we can get the supralabrum or the slap area near the biceps insertion. And then back here with ultrasound or without, we can do it blind. We can get the supraspinatus fossa and get that suprascapular nerve innervated in the rotator cuff in the joint. I'm going to do 3 little areas across the AC joint to get the joint as well as the AC ligament. All the way across the ligament, expands all the way around. And then we can frame the coracoid process here. Again, off the coracoid process, we have our muscles, short head of the biceps. We have the coracobrachialis coming off there. This is the AC joint. And we have our ligaments of our coracohumeral ligament coming off, coracoclavicular, coracoacromial. All those ligaments help stabilize the AC joint, and then the coracohumeral ligament helps to stabilize the rotator cuff and the biceps tendon as it spans over the bicipital groove. You doing okay up there? So I think what I'll do real quick is I'll do that, since I have quite a bit of lidocaine left, is I'll get that suprascapular nerve block on the suprascapular fossa. Again, that's a place too where the nerve can get impinged. Not only in the fossa, but also in the 2 notches, the spinal glenoid notch and the suprascapular notch anteriorly. So when you put a high volume amount of lidocaine in there, it'll block the nerve all the way through both notches and in the fossa. All right, I'll take the ultrasound probe cover. I'm afraid he's going to step in alpha position with his shoulders. Good. A little more. Let's do that block real quick. All right, Freddie, we'll bring the depth down a little bit, and we will make sure we can visualize the fossa. So on the left-hand part of the screen there, you can see the edge of the coracoid. That's pretty good. And then you see the supraspinatus tendon running in the fossa. Right here. So here's the supraspinatus fossa down here. So our needle's going to come down. It's going to hit the periosteum there. And then we're just going to do a kind of a higher volume block. You can see that in the bottom corner of the screen. You can see it spreading a little bit. It's a pretty deep area, so sometimes it's not the clearest image. So you can see we're just doing a high volume block of that fossa, and then if you keep going, it's going to spread anterior and posterior to get the posterior spinal glenoid notch and the anterior supraclavicular notch. Now what we're going to do is I'm going to flip over to ropivacaine, and we'll get a little bit of a deeper anesthesia through the attachments. Now on this one here, so the first one we'll do is we'll do the supraspinatus tendon. That one we can do internally rotated, and then we'll get this infraspinatus tendon, the AC joint, coracoclavicular ligament, coracohumeral ligament there, and some other rotator kind of blending zone between the supraspinatus and the infraspinatus there, labrum joint in the back. So let's get a little more lidocaine. So to get the supraspinatus tendon, internally rotate, adduct the arm, and then that'll bring the supraspinatus tendon on the greater tuberosity anteriorly. So you can see the bird's beak kind of appearance of the rotator supraspinatus there. We're going to come in and put a little bit of lidocaine under the deltoid to kind of get a subdeltoid block, and then we'll just go into the supraspinatus tendon, locking it through, and just getting some intertendinous blocks there for the PRP. Oftentimes, when you're kind of doing this steady, then you can start seeing some little rotator cuff gaps we want to fill in. All right, Freddie, if you want to. So the position for the subscap tendon and infraspinatus tendon is going to be an externally rotated arm with adduction again. So you can see we're externally rotating. It brings out, and you can see the subscap tendon there, kind of frayed at its insertion on the medial aspect of the biceps groove. Coming in. So it's kind of a tattered looking coracohumeral ligament there. And then we're going to walk a little more medial, and we're going to inject into the tendon a little bit, and then we get the subdeltoid block again over the tendon and muscle. That'll kind of numb it up as well. And keeping that externally rotated position, then I'll have you actually bring your whole body over a little bit, and then Freddie will keep that externally rotated. Then it's going to bring out the infraspinatus tendon attaching, there it is, and the posterior aspect of the lesser tuberosity. Come in, we're going to pepper against the deltoid area, and a little bit into the tendon to get those tendinosis areas, walking it down to the tendon. Okay, good. We go back to neutral, Freddie, and then yeah, and then you can roll forward a little bit, and then to get the labrum and the joint posteriorly. That's a nice view there. So that's going to be right under the labrum. That's into the joint. That's out again into the labrum. And we'll just kind of do a little volume block there to get that posterior labrum and joint area. Remembering too, the block we did up here to the suprascapular nerve should come through the spinal glenoid notch and numb up the posterior labrum as well. Good. So we'll let that kind of kick in. It's going to get the transition zone a little bit better between the supraspinatus and infraspinatus, because we'll look at that with the ultrasound as we're going through the procedure. All right, good. So she has quite a bit of glenohumeral arthritis, so I think we'll start with intra-articular and also the labrum posteriorly. All right, we've got a lot of solution to work with here. This is thrombin, and if I get some large rotator cuffs, I might fill in with a little thrombin to activate the PRP in the tears. Higher concentrated solution here that I'm going to put in the joint compared to slightly more dilute solution for the tendons, ligaments. A lot of stuff to work with here. First thing I'll do is just mix up the PRP a little bit. Just sometimes it clumps up, and we'll mix up the PRP. Just so it gets spread out. The joint first. So again, that position in neutral allows us to get into the joint. That's a nice view. Needle sliding under the labrum into the joint. So you can see the spread. How are you feeling? You okay up there? Mm-hmm. Okay. So I'll put about 3 cc's in the joint. I'm going to pull out. I'm going to go a little more shallow now. I'm going to get the labrum and the capsule and walk a little more shallow out to the bone acetabulum. And then we'll come down and we'll get some labrum injections a little bit more inferior. Inferior labrum, capsule. Okay. And I'll probably take a couple more reds too, and maybe one more 27 and a 4th. All right, slightly more diluted solution here. And a couple more reds too, Freds. couple more reds. All right. So now we can get the AC joint and ligaments. So I'll have you just relax in that position there. We're going to come on the top. So you can see the swelling over her AC joint, so positive geyser signs. You can see irregularities in the joint itself. You can see some fluid in there. So you can go out of plane to get into the joint. So just slip in the joint there. You can see the solution filling the joint. You don't want to over-distend this, it can be a little bit of pressure. And then we can come out, we can go on either side of the joint now too to get that ligament. So there's a ligament on the clavicular side. Then we just go back the other way, get the ligament on the coracoid side. So we're going to do the same thing now. I don't have to use ultrasound all the time, so this one is just a palpation technique to see how easy it is. Needle to the joint, pepper around, and then lateral to the joint, pepper around. Needle to the joint, pepper around, lateral to the joint, pepper around. Now stabilize the ligaments of the coracoclavicular, coracoacromial ligament we can get now. That's going to be coming off. If you throw the ultrasound on, you can see there that round little area in the middle of the screen. That's our finger-like projection of the chromium, of the coracoid process. And if we rotate, on top of it, if we rotate on top of that, you can see going in between the, right here, coming across in between, you can see the coracoacromial ligament. I should come back from this angle. And back up to the undersurface chromium. And then we can do the other way. Projecting back towards the clavicle. Doing okay up there? I think so. Rotate, there's the ligament coming off there. Clavicle and undersurface to get the coracoacromial ligament stabilized in the AC joint. Okay, now we want to make sure we have enough solution for the rotator cuff. I'm going to get a little more PRP. And mix it up a little bit. Supraspinatus is probably the most common area that's going to have tearing, fraying, tendinosis. So we're going to get that next. Infraspinatus is going to be internal rotation, or supraspinatus is internal rotation, abduction, and see if we can find the insertion point right where that little angle is. So pepper the insertion there. And if you go distal to the greater tuberosity, that's the aponeurosis insertion. Now that can continue all the way down the shoulder. So if we go here from this view, and we can hit just distal to the greater tuberosity and get that aponeurosis. Aponeurosis is important because it kind of creates a lever action or lever type of attachment, extending the leverage of the supraspinatus tendon. So it doesn't just insert there, but attaches all the way down about 3 centimeters. So we can do that from a few of these skin blebs to kind of get the rotator cuff and cross section, a few different views. There's something to go right from here. Inject some of those areas that look a little bit more tattered. So she doesn't really have a full tear, just a lot of little supraspinatus, smaller gaps in tendinosis type areas. Now I have my assistant put the arm in external rotation and adduction to get the rotator interval as well as the, so you can see the biceps tendon, yeah, and then slowly externally rotator. There's a biceps tendon in the middle. So when he externally rotates, it's going to bring out the lesser tuberosity anteriorly, and then the attachment of the subscap tendon there. So you can see your subscap's pretty tattered, so I'm going to come in and get into, that's right on the lesser tuberosity, so that's right where the coracohumeral ligament is attaching. I just slipped into the subscap tendon, and then we can walk it out into the subscap tendon. Again, the coracohumeral ligament is so important, so I'm going to pepper that attachment there. And then we can pepper the attachment on the other side with the lateral coracohumeral ligament attaching there and blending with the supraspinatus tendon, or the supraspinatus tendon. Okay, done right. Good. And relax it down. So we got the coracohumeral ligament at the rotator interval. Now we can come out more medially, and then you can see the coracohumeral ligament attaching right here, attaching to the coracoid process. So coming across and attaching over the bicipital groove. So we come there. There it is. That's needles on the coracoid process. Then I'm going to walk just inferior to it, and the ligament is right there. So I'm getting that attachment there, peppering it as I go. If you wanted to, you can just go mid-body of the coracohumeral ligament there. You can see it's spreading mid-body of that ligament. Super important ligament for stabilizing the rotator cuff and the bicipital groove. You okay?
Yeah, I shake, but I think that's some of the latitude.
Okay. We're going to get you ice down here in just a second. Okay, I'm just going to finish with her using platelet PPP with prolotherapy just to get the rest of the infraspinatus posteriorly. So I'm almost done. So again, I'll have my assistant externally rotate and adduct the arm. That'll bring the infraspinatus tendon and the greater, so go ahead and rotate forward. Infraspinatus tendon on the lesser tuberosity into the injection viewpoint there, so you can see the muscle coming across and attaching there right at that pinnacle peak. We're going to come in right from our mark. And shut down. To those areas, that tendon's that hurting you, you okay? Mm-hmm. And then you can bring it down to neutral. And the last thing I usually do at the very end is I'll just kind of scan across underneath the deltoid just to visualize the blending area between the supraspinatus and infraspinatus tendon. And then I'll usually just go out of plane here, the blood that I have coming across. And then we'll just pepper out of plane that attachment there. Getting more interior now, so getting more probably supraspinatus fibers. Getting more posterior now. This is where they're going to blend together. The last one you can get is if you kind of go straight down. This one's hard to see with ultrasound. If you go straight down to that taps bone, this is going to be right where the superior labrum is going to be attaching that slap area, the biceps tendon. And as you pull out, you can inject a little bit of PPP through here to get the supraspinatus tendon, which uses more of the supraspinatus muscle. So I'm pulling out through the supraspinatus muscle in case there's any tears, extending it back into the fossa there. So she's going to be a little bit sore afterwards. We're pretty thorough there. We've got a lot of spots. But in the end, it's going to induce a good healing. So what I usually do after this is I will have them rest. We're going to pack her in some ice just to decrease the initial flare of that PRP. And then we will usually have her follow up in about 10 weeks. She'll start physical therapy in about a week to start going through a protocol for the rotator cuff. Since she doesn't have a full thickness rotator cuff tear, we can be a little more aggressive with that. Usually we're going to put her into a sling for comfort afterwards. Give her some medication for pain afterwards. We'll get her on her post-procedure supplementation plan. We'll see her back in about 10 weeks.